Hello, everybody. This is Dr. Ashur. We are going to continue our series about pharmacologic treatment of heart failure. We said before we subdivided this topic into three subtopics. Topic number one is pathophysiology of heart failure. Subtopic number two is drugs in heart failure. Subtopic number three is inotropic drugs in heart failure. In our previous video, Pathophysiology of Heart Failure Part 1, we talked about the definition of heart failure, its etiology, prognosis, and epidemiology. Then we talked about some cardiovascular physiology concepts, and we ended up with the clinical features of heart failure. We talked about the signs and symptoms. Today, we are going to continue the part 2 of pathophysiology of heart failure, which will start right now. Well, in this part of pathophysiology of heart failure, part 2, we are going to define or know the types of heart failure. We'll discuss the pathophysiological mechanisms of heart failure, and then we'll talk about the compensatory mechanisms that the failing heart is trying to perform to regain the normal cardiac output. Okay, number one, the types of heart failure. Okay, we have different classifications. Okay, number one, the classification according to systolic and diastolic. So we have systolic failure and diastolic failure. Okay, start first with the diastolic failure. About 50% of younger patients have such type, so it appears more in the young age. It's characterized by reduced mechanical pumping action, reduced contractility. Because please focus, because there is a big difference between the diastolic and systolic failure. The ventricular walls become thin. Okay, please focus. In diastolic failure, they are thick, okay, weak, and they enlarge, they get bigger, okay, are in loose tone as they stretch out. And it's associated with reduced ejection fraction. We said before the ejection fraction about the normal person is about 50, 60%, 70%. Between 40 to 50% is kind of borderline, so it's not heart failure, but less than 40%, it's kind of starting the issue of heart failure. So what happened here is, we said among the etiology, there is the coronary artery disease. So now coronary artery supplies the heart or support the heart with blood. The cardiac muscle itself gets its nutrition through the coronary blood vessels. If there is a coronary stenosis or coronary artery disease, thrombosis, whatever, so now the amount of blood or the blood supply to the heart is less. So this could be associated with myocardial infarction, so death of part of the muscle of the wall of the heart, okay? So this will result in reduced contractility. The cardiac muscles try to stretch out, okay, to fill more blood so that they can push more blood, but they get thin and they get weak by time. And in turn, the ejection fraction will become less because the stroke volume will be less. Okay, the second type is the diastolic failure. Okay, diastolic refers to diastole, systolic refers to systole when the heart contracts. Diastolic refers to the diastole when the heart relaxes. Okay, number one, the proportion of patients with this diastolic failure increases with age. So increases with age. It's characterized by hypertrophy. So now there is thickness of the ventricular wall as compared to thin ventricular wall. Okay, thickness and stiffening of the myocardium. So it's not only thick, but it's stiff. Does not push as hard. Okay, the movement is sluggish, cannot move easily. the myocardial wall. And loss of adequate relaxation also. So it cannot accommodate more blood, so reduce the filling, and hence reduce cardiac output. Okay, so so now if the filling is less, this means that the amount that's coming out will be less also, right? So the ejection fraction may be normal. Doctor, is it normal during diastolic failure? Yes. It's heart failure, doctor? Yes. The ejection fraction is normal. But it's not because everything is normal. It's because the stroke volume itself is reduced, which is in the numerator. It's up there. Remember, ejection fraction equals stroke volume divided by end-diastolic volume. Stroke volume decreases, but also end-diastolic volume decreases because of the reduced filling. So the numerator and denominator both decreases, so the final will be the same. Okay, please refer back to the equation in the previous video and see it. And suppose like you have 2/4, okay, 2/4. If you convert it into 1/2, same thing, right? Same thing. This is what's happening here. Reduce the filling, so reduce end-diastolic volume. Due to the hypertrophy, okay, so the size of the heart, okay, that can pump blood is less, so the stroke volume that's coming out will be less. So I try to like make like a good example by this water model. Okay, so now in systolic, a normal person, if you push, okay, the water will come out up here. Okay, hopefully it does not spill. But in systolic failure, the pumping action is less. Okay, the water comes like the blood that's coming out is less. Okay, but in diastolic failure, the amount of water itself, or the blood itself, I'm sorry, is less. So even though the pumping action could still be okay, but the amount of blood itself is less because of the reduced filling or reduced end-diastolic volume. So again, the amount that's coming out of the heart is less. Okay, so again, please pay attention. In both, the stroke volume is decreased. In both types, the cardiac output is decreased. Okay, but here the end-diastolic volume also decreases, which makes the ejection fraction is almost normal, maybe 50–60%. Okay, so in a graph, we can also see this. So this is the normal heart. Okay, during diastole there is a filling, okay, and during systole there is a pumping. Okay, the ventricles will fill normally with blood during diastole, and during systole the ventricle pumps out about 60% of the blood, which is the ejection fraction. And systolic dysfunction, we said there is chamber dilation. Okay, the enlarged ventricle will fill with blood, which is okay so far. But the ventricle pumps out less than 40–50% of the blood because the muscle itself is weak, does not push as hard as it should be doing. On the other hand, the diastolic dysfunction, okay, there is a stiffness and there is hypertrophy also. And the ventricular wall, as you see here, okay, so the filling is the issue here. There is less filling, okay, so again, the amount that's coming off the heart will be less, not because of the weakness of the muscle, but because of the reduced filling. So the heart will pump 60% of the blood that's in the heart, but it's already less. Okay, that's why the ejection fraction will be almost normal. Okay. Okay, another classification is whether it is right-sided heart failure or left-sided heart failure. Sometimes they call it also right heart failure, left heart failure, but I'm afraid they have to say right heart failure, and this is wrong heart failure. This is wrong, okay? So right heart failure, left heart failure. I'd like to start with left heart failure because usually this is the form of heart failure that starts in the beginning. Okay, this one will show decreased cardiac output. Please again put here also there is also decreased cardiac output, but the mechanism is different. Okay, decreased cardiac output. So now the patient will easily get tired when doing any exercise. okay, activity intolerance, and signs of decreased tissue perfusion. Because of the weakness or the contractility of the heart, as we said, there will be backup of the blood to the lung, okay. So it's left-sided heart failure. I'm talking about the left ventricle, okay. So left ventricle and left atrium receives the blood from the lung, right? So the blood will be back up to the lung, and this will cause pulmonary congestion. This will be associated with impaired gas exchange with signs of cyanosis and hypoxia. Pulmonary edema, which can cause orthopnea, which is the dyspnea or shortness of breath when the patient is lying on a bed or couch, whatever. Cough with frothy sputum, because now there is a congestion. There's more fluid in the lungs, so the body, as a reflex, trying to expel, to push these fluids out through a cough, okay. And paroxysmal nocturnal dyspnea, and this is, as we said, at night when we're sleeping, there is a distribution to the central circulation, which again will cause more pulmonary congestion, more dyspnea. On the other hand, right-sided heart failure, or right heart failure, okay, there is a congestion in peripheral tissue. Remember, the right side of the heart, this is the right side of the heart, it receives the blood from the superior vena cava and inferior vena cava from all body tissues, okay? On the left side of the heart, it receives the blood from the lung. That's why here you have pulmonary congestion, here you have peripheral congestion, okay? Because this receives the blood from everywhere in the body, okay? So there will be liver congestion because of accumulation of fluids in the liver. There will be signs of impaired liver function. GI tract also congestion. There will be anorexia because there are so much fluid and ascites and stuff. So there will be loss of appetite, weight loss, and gastrointestinal distress. There will be also, because there is a stagnation of the fluids in the leg and feet, okay, there will be dependent edema. Dependent edema means that edema that's dependent on gravity. When the patient is standing, okay, the fluid will be by gravity will be collected or will be stagnated in the lower extremities, like in the foot and leg. That's why you have this dependent edema. Okay. Okay. So this is for right and left-sided heart failure. Okay. Now to explain a little bit on the pathophysiology of what's happening. Okay. Number one, we'll start with the Frankstarling relationship. Okay, it describes the fundamental relationship between what's in the heart, the preload, and the cardiac output. The preload and the cardiac output. Stroke volume times heart rate is cardiac output, right? So easy. So now, whenever you fill the ventricle more with blood, okay, the stronger the stroke volume, or the more stroke volume. The stronger the contraction, the bigger the stroke volume. So more. So here's the normal. More until certain level. However, in patient during like exercise or whatever, okay, this will increase, okay. So normally when there is increase in the initial volume, the ventricle increase the strength and subsequent ventricular contraction, okay. During a period of increased adrenergic drive, like during muscular exercise, you are climbing stairs, playing football, whatever, okay, any adrenergic drive increase, okay, the Frankstarling relationship is shifted up and rightward. Sorry, up and leftward. Okay, so this is the normal, sorry. So this is the normal, okay, so up, and this is the normal. Left to it is the during the muscular exercise. We are talking about just physiology, normal person, no problem, okay. So this is the normal, okay. So now because the pumping of the heart, remember we said during exercise the cardiac output increases, right? 3 to 5 times. Ejection fraction can increase to about 90%. So this is what's happening here, okay. This will support the tissues demands during this muscular exercise or whatever. During the heart failure, the relationship is shifted downward. Again, this is the normal. Okay, this is the normal. So the the relationship or the curve is shifted downward and rightward, down and right, okay? So now the response of the cardiac muscle to the increased end diastolic volume is less, okay? So, so with the compensatory mechanism that we're talking about, we'll talk about them in a minute, or treatment, you can increase a little bit the Frankstarling relationship, but usually not to the optimal level, okay? So there will be some increase in this or shift up and lift of upward and liftward of the Frankstarling relationship, okay? So now there is a term you always hear about compensation. What's compensation? These are the mechanisms that the heart now will try to do to save the situation now. Okay, now there is less blood perfusion, okay, to the tissues. So the blood is the heart's trying to do something, okay, or the cardiovascular system generally is trying to do something. So number one, on the level of the baroreceptors, because of the lack of sensitivity of the baroreceptors and also the less amount of blood, the cardiac output is less, so the baroreceptor firing will be less. So this will activate the sympathetic nervous system, okay, sympathetic nervous system. So less firing, more activation of the vasomotor center, activation of sympathetic nervous system. We know sympathetic nervous system will increase the heart rate and also will increase the contractility of the heart. This what will do, it will increase the cardiac output, because increasing heart rate will, so heart rate more, contractility will increase stroke volume, heart rate times stroke volume equals cardiac output. Okay. This is number one. Number two, there is less renal perfusion. So there is activation of sympathetic nervous system itself will activate the beta receptors in the juxtaglomerular cells in the kidney. This will activate the renin-angiotensin-aldosterone system, okay, due to the decreased glomerular filtration rate. Okay, so this will cause activation at the end of angiotensin 2, which will cause aldosterone release. Aldosterone itself will cause sodium and water retention, so fluid retention, okay, and also can cause vasoconstriction. So the fluid retention can increase the preload. From the Frankstarling relationship, if you remember, increasing preload can increase to some extent the contractility of the heart. Okay, now cardiac output increase. The third mechanism is, do you remember we said one of the causes, the etiology of heart failure is the hypertension. So when there is a vasoconstriction of the blood vessels, there is too much stress on the ventricular wall, so increased ventricular wall tension. So the heart is trying to compensate for that. So what does it undergoes hypertrophy or myocyte growth. Okay, so this will increase the force of the contraction. This again can increase the cardiac output. These are the compensatory mechanisms. Unfortunately, these are the mechanisms that can correct little bit the hemodynamics of heart failure to some extent, but unfortunately they can lead also to pathologic remodeling and decompensation, as we'll see in this next slide. So again, so there is generally speaking, diastolic, systolic, right-sided, left-sided, there is decreased cardiac output. Okay, decreased cardiac output. So now decreased cardiac carotid sinus firing. So the baroreceptor, there is less firing. Okay. So now increased sympathetic discharge. Sympathetic nervous system will increase the force of contraction through the beta receptors, rate of contraction, the heart rate from the beta 1 receptor also will increase also the venoconstriction, increase the preload, and will cause vasoconstriction through the alpha 1 receptor, so it will increase also the afterload. Okay, all of these things will try to increase the cardiac output by compensation. Okay. Okay, the second way, or second pathway, through decreased renal blood flow, okay, so decreased GFR, increase in the renin release, because beta receptors will activate the sympathetic nervous system, okay, can activate the beta receptors in the juxtaglomerular cells, which will lead to increase in renin release. As you know, renin release will facilitate the conversion of angiotensinogen into angiotensin 1. Then with the ACE, angiotensin converting enzyme, it will convert angiotensin 1 into angiotensin 2. Angiotensin 2 itself is vasoconstrictor, so it can increase the afterload. Also, it can cause increased aldosterone release. Aldosterone causes sodium and water retention. This will cause increase in preload. Angiotensin 2 also can increase. Here, before I go to that, also it enhances norepinephrine release. So you see here, both are helping each other. Okay, trying to save the situation, but unfortunately, they end up with decompensation where the heart fails, okay, to pump sufficient blood to the tissues. The third thing is angiotensin 2, along with also the with epinephrine, they can cause myocyte growth myocyte apoptosis and structural change of the myocardial cells. So this will lead to progressive remodeling. So this is called post-pathologic remodeling. During exercise in the athletes, there is physiologic remodeling, which is the structure, change in the size, shape, structure, and function of the heart, okay? But in physiology, like in athletes, this is normal. But here is due to the injury to the cardiac muscle, is called pathological remodeling. Pathological remodeling, okay? Which includes progressive chamber dilation, okay? Loss of contractile function, the contraction is weak, okay? And ventricular hypertrophy. Remember, there is some death in the like infarction in part of the myocardial muscles. So the other muscles are trying to compensate for that. You remember, like during football or whatever, when a player receives a red card, the other player has to do much harder work, right? So this kind of similar to that, they are trying to undergo hypertrophy. So these three mechanisms are mechanisms of the remodeling that happen to the cardiac muscle due to these compensation mechanisms. It's called pathologic or pathological remodeling. Okay, I think that's it. Thank you so much, and we'll talk to you later when you talk about inotropic drugs. Sorry, we'll talk about drugs in heart failure, generally speaking, drugs in heart failure. And in the last part, we'll talk about inotropic drugs in heart failure. Thank you, and talk to you later. See you, and have a great day. Bye.